Falls among older adults are a major public health issue worldwide. As people age, the risk of falling increases, leading to serious injuries, loss of independence, and even death. In Switzerland, for example, 25% of those aged 65 and over, and half of those over 80 report at least one fall each year. These incidents can have profound physical, psychological, and social consequences, making fall prevention a top priority in healthcare settings. Understanding the factors that contribute to falls is essential for developing effective prevention strategies and ensuring the safety and well-being of our aging population. Not all falls are accidental. Many are linked to modifiable risk factors such as balance deficits, impaired gait, environmental hazards, and importantly, medications. Polypharmacy, or the use of 5 or more medications, is common among older adults and is a well-known contributor to fall risk. Identifying these risk factors allows healthcare professionals to intervene early and tailor prevention strategies to each individual's needs. This proactive approach can significantly reduce the likelihood of falls and their associated complications. All-risk increasing drugs, or FRIDs, are medications that can make older adults more likely to fall. These include certain psychotropic drugs, antiepileptics, opioids, and diuretics. FRIDs can cause side effects like dizziness, confusion, sedation, and low blood pressure, all of which can lead to a dangerous fall. Recognizing and managing FRIDs is a key part of fall prevention in hospitals and nursing homes. Help clinicians identify and manage FRIDs. The Stop Fall tool was developed. Stop Fall stands for Screening Tool of Older Person Prescriptions in Older Adults with High Fall Risk. It provides a comprehensive list of 14 medication classes that are considered high risk for falls. This tool is based on systematic reviews, guidelines, and expert consensus from across Europe, making it a valuable resource for improving medication safety in older adults. Recent Swiss studies set out to examine how common FRIDs are among hospitalized older adults, using the Stop Fall tool. Researchers also wanted to see if FRID prescriptions changed during hospital stays, especially for patients identified as high fall risk by nurses. Finally, they explored whether being prescribed FRIDs was linked to actually falling during hospitalization. The study was retrospective, analyzing health records from one hospital over a year. The study included 741 patients aged 65 and older who were admitted to internal medicine units. About half were women and more than half were aged 80 or above. Most lived in the community before admission, and nearly 3/4 were taking 5 or more medications. This group represents a typical frail, polymedicated older population at high risk for falls and medication-related problems. Nurses used the Stratify score to assess each patient's risk of falling. This tool considers factors like confusion, vision problems, frequent toileting, recent falls, and mobility status. A score of 2 or more indicates high fall risk. In the study, 44% of patients were identified as high risk, and 40% reported a fall in the previous year. Accurate risk assessment is crucial for targeting interventions and preventing future fall. At the time of hospital admission, 72% of all patients were prescribed at least one FRID. Among those at high risk of falls, the number was even higher, 75%. The most common FRIDs were diuretics, benzodiazepines, and opioids. These medications are known to cause side effects that can increase the risk of falling, highlighting the importance of careful medication review upon admission. During hospitalization, there was a significant reduction in FRID prescriptions. By discharge, only 64% of all patients and 63% of high-risk patients were still prescribed at least one FRID. This suggests that hospital stays provide an opportunity for healthcare teams to review and adjust medications, potentially reducing fall risk before patients return home or move to another care setting. Most frequently prescribed FRIDs at both admission and discharge were diuretics, benzodiazepines, and opioids. At admission, 36% of patients were on diuretics, 32% on benzodiazepines, and 23% on opioids. At discharge, benzodiazepines remained high at 30%, with diuretics at 28% and opioids at 18%. These numbers show that while some deprescribing occurs, high-risk medications remain common. Nurses play a vital role in identifying patients at risk of falls and advocating for medication reviews. When nurses documented a high fall risk, patients were less likely to be discharged with a FRID. This highlights the power of interprofessional collaboration. Nurses, doctors, and pharmacists working together can make a real difference in patient safety. Interestingly, the study found no significant association between being prescribed a FRID and actually experiencing a fall during hospitalization. Only 2% of patients had a documented fall while in the hospital. However, the number of falls was small, so more research is needed to fully understand this relationship. Prescribing or safely reducing or stopping medications can be challenging. For example, stopping benzodiazepines often requires a gradual taper to avoid withdrawal symptoms. Despite these challenges, the study showed encouraging reductions in FRID use during hospitalization, especially when nurses were actively involved in fall risk assessment. Offers practical guidance for clinicians, including decision trees and evidence-based advice for each medication class. By using this tool, healthcare professionals can make more informed decisions about which medications to continue, adjust, or stop, always with the goal of reducing fall risk and improving patient outcomes. Like all research, this study had some limitations. It was conducted at a single hospital, so the findings may not apply everywhere. The data relied on electronic health records, which may not capture every fall or medication change. Also, the Stratify score used to assess fall risk has limited accuracy, and some patients may have been misclassified. Despite its limitations, the study had several strengths. It used a large sample of older adults and followed robust research frameworks. The use of standardized data extraction and the focus on multiple aspects of patient health, like comorbidities, nutrition, pain, and confusion, provided a comprehensive view of fall risk in hospitalized older adults. Findings suggest that incorporating stop-fall into clinical practice can help identify high-risk medications and support targeted medication reviews. Nurses, in particular, can use this tool to advocate for safer prescribing and deprescribing, ultimately improving outcomes for older adults in hospital settings. More research is needed to confirm these findings in larger and more diverse populations. Future studies should also explore the experiences of both patients and clinicians and test whether nurse-led fall risk assessments directly impact prescribing practices. This will help develop more effective, person-centered fall prevention strategies. While reviewing and deprescribing FRIDs is important, it's only one part of a comprehensive fall prevention strategy. Other factors, like mobility, vision, continence, and environment, must also be addressed. A multifactorial approach tailored to each patient is the most effective way to reduce falls and promote healthy aging. To maximize their impact, nurses need more education in pharmacotherapy and deprescribing. Integrating these topics into nursing curricula and ongoing training can empower nurses to take a more active role in medication safety and fall prevention, benefiting both patients and healthcare teams. In summary, falls are a serious risk for older adults, and medications play a significant role. Tools like Stop Fall combined with nurse-led assessments and interprofessional collaboration can help reduce unnecessary FRIDs and improve patient safety. Ongoing research, education, and a multifactorial approach are essential for effective fall prevention in our aging population.